Hello, this is Dr. Robert Keller from Northern Arizona University. We're going to be discussing respiratory diseases. There'll be two parts to these presentations, part one and part two separate video files. First, to get started, let's look at a couple of different categories of the diseases that we'll examine. We're going to be focusing on atelectasis, obstructive pulmonary disease, restrictive pulmonary disease, and pulmonary infections. There's quite a few others to add to this list, but we're going to focus our discussion on these four. A little bit of review and some possibly new terms before we get started. You can see here a figure that's adapted from an anatomy and physiology textbook. So this is really from respiratory physiology and second semester anatomy physiology. I want to refresh your memory about different terminologies such as total lung capacity, shown on the far left with the largest arrow, the vital capacity, the theoretical range of 4,500 to 5,000 milliliters. You've got inspiratory reserve volume in blue, and you have expiratory reserve volume in this lime green. We have a tidal volume that fluctuates in between those two that's about 500 milliliters. And that represents the volume of the exhaled air after normal inspiration. So when we look at respiratory disorders and we consider the pathology, we first need to look at normal physiology and what's taking place. Some of the terms that we're going to come across, terms like eupnea, the Greek term really meaning specifically well breathing is how it translates. So it's actually normal, good breathing. Dyspnea, shortness of breath, or abbreviated SOB. Orthopnea, shortness of breath that occurs when a patient's in a horizontal position or laying down. Hyperventilation versus hypoventilation. Hyperventilation, which exceeds metabolic demands, and hypo is where it's below metabolic demands. Likewise, hypercapnia versus hypocapnia in reference to CO2 levels in the blood. So hyper being high CO2 in the blood and hypocapnia being low CO2 in the blood. Hemoptysis, this clinical term refers to the coughing of blood or blood being found in sputum that comes up out of a patient. Cyanosis is a blue tint or a blue color to the skin or the mucosa, typically indicating a decrease in oxygen or a decrease in hemoglobin, so a decrease in oxygen in the blood or challenges with hemoglobin concentrations. Hypoxemia, not necessarily hypoxia, but hypoxemia, this is a decreased oxygenation of arterial blood, and hypoxia is a decreased oxygenation of the tissues. So the first term, hypoxemia, refers to the oxygenation levels within your arterial system, and hypoxia is really reference to tissues or cellular level. This brings us to our first pathologic term, atelectasis. This is really lung collapse. Lung collapse where the lung is not expanding appropriately or adequately. It therefore will manifest and cause a reduction in oxygenation within the body. We can see three different varieties of atelectasis on the right side of the slide: resorption, compression, and contraction. Resorption is when there's an obstruction that prevents air from reaching the distal airways. So you can see in that image of resorption on the right side of the slide, the upper left image, you can see that there's actually an obstruction in one of the bronchi. So air that's present becomes absorbed and eventually the alveoli collapse. In compression, on the upper right, you have a situation where it's also known as a passive or a relaxive compression. It's usually due to an accumulation of fluid or blood or air in the pleural cavity. It induces a mechanical type of collapse. It's often seen associated with pleural effusions due to CHF or congestive heart failure in patients. Another situation would be from a pneumothorax where during trauma or an event, the thorax cavity becomes compromised, and you have an impalement or an object that's compromised that pressure differential, and that would be considered a pneumothorax. Lastly, contraction at the bottom image on this slide. You can see what's happening there. There actually are fibrotic changes associated with the lungs, and this hampers lung expansion. So there is essentially an increase in the elastic recoil, and these fibrotic changes induce the lung to contract down on itself. So atelectasis, essentially lung collapse, 3 different scenarios caused typically by at least 3 different mechanisms. So moving on, we're going to move into chronic obstructive pulmonary disease, and we're going to look at this in 2 parts. What is it? Obstructive pulmonary diseases generally are reduced airflow due to a partial or complete blockage. It's exaggerated or it's worse with expiration. We're going to look at 4 different types of obstructive pulmonary diseases. You can see them listed here: emphysema, chronic bronchitis, asthma, as well as bronchiectasis. Now, the first 2 are traditionally and classically referred to as COPD, or under the category of chronic obstructive pulmonary disease, because of their chronic nature. The last 2 are obstructive pulmonary diseases, but they're really not conventionally referred to as COPD. Asthma, one may argue, asthma is chronic. Patients have had asthma their entire life, but the reason it's considered more acute and intermittent is oftentimes an asthmatic is managed or treated for their symptoms. So if they had a chronic asthma attack where they never were receiving a bronchodilator or a rescue medication and an inhaler, or they weren't on a theophylline of some sort, then they would probably manifest with more of a chronic obstructive pulmonary disease. But because it's a treated clinical symptom, it is obstructive, no question there, but it's usually not considered chronic. Bronchiectasis is an abnormal dilation of the bronchi. It's often associated with bronchitis. It has very similar symptoms. There's purulent sputum, spit up that comes up. We're going to get to this. And this is where with bronchiectasis you see the hemoptosis, where you get the coughing up of blood. So let's start and let's go down the list. First up is emphysema. What is emphysema? Okay, it affects the acinus. You essentially have a disorganization of the alveoli. You lose surface area. You have enlargement or swelling of the alveoli, typically distal to the terminal bronchi or bronchioles. And so this would be, as you can see from the cartoon drawing, towards the mid part of the slide and below, the acinus, the normal acinus shown in green. You've got your respiratory bronchiole or bronchi, and it terminates into an alveolar duct, and then at the very end you see the alveolus. And so this region of the acinus is typically what's compromised. You can see the corresponding images at the top of the screen where you've got hematoxylin and eosin stained sections up at the top of the screen with the histology, and you can see that there's large gaps. You've got marked enlargement of the air spaces prevalent in that hematoxylin eosin stained section. And so it has a thinning and a destruction of that alveolar septi. 2 different types that we'll look at and characterize, centriacinar and panacinar. Centriacinar is actually more common. It's very closely associated with upper lung lobes. It's very commonly associated with cigarette smoking in our chronic cigarette users. You can see what's going on graphically with the cartoon drawing in the image labeled B with the centroacinar emphysema. You've got the respiratory bronchiole that's actually affected. In contrast, panacinar really affects the alveolus and the duct, and so that's panel C in the cartoon drawing on your slide. And it's more common in the lower lung zone, and it's actually seen associated with an alpha-1 antitrypsin disease. Okay, now this alpha-1 antitrypsin is also referred to as an anti-elastase. Okay, so this enzyme, ACE, it ends in an ACE, so it's an enzyme. This tends to prevent the digestion of the protein elastin. And normally, elastin is important in lung tissue to facilitate for elastic recoil. So in these patients with Panacenter, there may be no cigarette smoke present. It may be a genetic defect or a congenital malformation that's happening, and you have a misexpression of alpha-1 antitrypsin. Okay, so we'll talk a little bit more about that here in a moment. So looking at the cause or looking at pathogenesis of emphysema, it's typically not exactly clear. Okay, we don't have a clear understanding of what exactly causes it. There's two most likely issues that are going on here. So you've got first an imbalance between protease and antiprotease activity, and this is really what we were talking about just previously on the first slide, which was alpha-1 antitrypsin. This inhibits elastase, and it prevents the breakdown of elastin. So you can see right in the middle of the slide in the language, there's an arrow that goes down from tobacco to reactive oxygen species, or ROSs, to the inactivation of antiprotease functional alpha-1 AT. That's that alpha-1 antitrypsin. Okay, so there is a linkage that's believed to occur where it's closely associated with antioxidant imbalance as well. So you have tobacco smoke, the nicotine enters the bloodstream. You have reactive oxygen species. Tobacco has a tremendous amount of ROSs present. That tends to inactivate this alpha-1 antitrypsin, and that facilitates an increase in the production of elastase from neutrophils. Neutrophils are present because you have an irritant in the respiratory lining, and so there's a inflammatory response that's taking place. And if you remember back to wound healing in the beginning of the semester, when we looked at inflammation, we know that there's a neutrophil infusion, and those neutrophils can actually increase the production of elastase to break down elastin, cause tissue damage, which is shown towards the right side of the slide in that sort of red spherical region, and that tissue damage then has activity at the level of the alveolus. So it's a complicated pathogenesis. We don't exactly know which comes first, but we do know that there are involvements with reactive oxygen species. We do know that alpha-1 antitrypsin is influenced, and we see structural changes within the alveolus at the level of the alveolus or the aciner, like we were talking about previously. All right, let's talk now about some of the clinical manifestations. Okay, so here's that word again, shortness of breath, dyspnea. These patients tend to be identified as pink puffers. What that terminology is referring to is there usually is a forced expiration that's necessary. It's usually prolonged. Patients will become barrel-chested from an increased use of their diaphragm and respiratory muscles. Because of this increased muscular effort required, the patients usually become pink or red in the face due to the difficulty of exhaling. Okay, so in this particular situation with emphysema, you've got barrel chesting, you have some weight loss that takes place over time. It's thought that the weight loss with emphysema patients is closely associated with the increased respiratory effort, and maybe even the loss of skeletal muscle, some atrophy of the skeletal muscle because of a hypoxia that's a side effect of not being able to respiratory move and exhale the air quite as quickly. Moving on to the next category on our list is chronic bronchitis. Okay. So let's take a moment to compare and contrast chronic bronchitis to emphysema. You can see from the schematic or the cartoon drawing on the slide On the left side is characteristics of chronic bronchitis. On the right side of the slide are characteristics of really a pure emphysema type of situation. So we just left emphysema. Let's start there. We see that it affects the sinus, the respiratory bronchiole, the alveolar ducts, the alveoli. There's a loss of elastic recoil. This is classic emphysema. Over on the left side, you can see that it's affecting more of the large and small airways. Okay, it begins in the large airways and it makes its way to the smaller airways. It's common that these patients will have a persistent productive cough. What that terminology means, productive, is they're actually producing sputum. They're coughing up sputum. In contrast, sometimes when patients are sick and there's that real non-productive or aggressive cough, but it never really creates any sort of sputum that comes up, and that would be considered non-productive cough. So in pure chronic bronchitis, these large airways are being irritated. There's an inflammation. Small airways could be influenced later in the process. 3 different types that we need to characterize: simple, chronic asthmatic, as well as chronic obstructive. So in our simple case, mucus is present, but the airflow is not obstructed. In a chronic asthmatic situation, you have intermittent bronchospasm in addition to mucus production. And then lastly, the last category on this slide at the very bottom, chronic obstructive. Here the mucus is so thick that it actually blocks the respiratory tree, and this is classically seen in smokers. So while there's no definitive pathological finding, we can define what chronic bronchitis is clinically. And the way that it's defined is the following: persistent productive cough for at least 3 consecutive months in at least 2 consecutive years. So that would be a patient that would be diagnosed as having chronic bronchitis. Let's look at the pathogenesis. In chronic bronchitis, we see there's a loss of the pseudostratified epithelium. You can see the image at the top of the slide, the histology at the top of the slide, where you can see the cilia, the little hair-like projections that are pointing upwards. You can appreciate the pseudostratified nature of this epithelium. We know that we're in a respiratory bronchiole or somewhere within respiratory epithelium. We also can see goblet cells. These goblet cells are really nicely characterized in this top image. You can see there's a lot of red staining of the nucleus, more orange staining of the cell structure, the cytoplasm, as well as the cilia. And then the goblet cells are sort of more translucent and off-white with some kind of gray speckles. And you can see right in sort of just left of the middle center of this top histology image, you could see a goblet cell that has its opening to the surface, the superficial surface of that ciliated epithelium, and that's the mucus is able to be released there. Okay. So here we see with pathogenesis a loss of pseudostratified epithelium from that normal phenotype. There tends to be an environmental trigger. That trigger of the mucin gene is going to increase goblet cell production of mucus. Okay, so some irritant in the environment can cause a mutation and upregulate the production of mucus. Okay, so the mucin gene can actually be turned on. It can actually be turned on by certain environmental factors such as air pollutants or cigarette smoke. If we look at what's going on here, you see hypertrophy or swelling of the submucosal glands, and it typically begins, like we mentioned earlier, in the larger airways, and then it moves down into the smaller airways. Infection often follows in this situation of chronic bronchitis. If we look at the clinical features from this patient, very, very different when we contrast it with what we saw with emphysema, although it is common to see bronchitis associated with emphysema patients. Those patients tend to be in really bad shape, meaning clinically, not necessarily physically. Physical, obviously, there are some challenges you can see from the 2 images that we've just shown, but we classically refer to them as blue bloaters rather than pink puffers. And it's usually because they have less prominent dyspnea, or shortness of breath, and respiratory drive. They retain CO2. They become hypoxic and cyanotic, meaning it's more bluish in color. That's where we get our blue bloater reference. They do tend to be obese. It's not exactly known as to why. Slightly overweight or overweight. The airways tend to close during exhalation. That causes an increase in CO2 to the brain that basically resets to a hypercapnia. And again, like I mentioned previously, they have a bluish or cyanic appearance with cyanosis, which is that bluish tint. They have cough with sputum, so it is a productive cough, and they have shortness of breath on exertion when they try to do physical activity. So very different clinical appearances of a pink puffer and a blue bloater. Okay, moving from the chronic obstructive pulmonary diseases, which was part 1, into a part 2 where we're looking at obstructive pulmonary diseases such as asthma and bronchiectasis. So let's first take a look at asthma. And there's a lot going on within an asthma patient. Usually starts in childhood, affects about 2 to 3% of the population. There's 2 main pathways that we can look at. There's an extrinsic pathway and there's an intrinsic pathway. This extrinsic pathway is dominated by an allergic response. It's a type 1 reaction. It is IgE mediated. There are certain patients, if you recall back to our immunology section in this class, atopic individuals are genetically predisposed to have higher than normal or higher than average IgE and eosinophil levels. So they may be more predisposed to having an extrinsic type of allergic induced asthma. Okay. So is there a potential genetic component to asthma? Absolutely. It's also referred to as bronchial asthma. Okay, so that's another name for it. When we look at the extrinsic pathway, things that can cause a trigger are smoking, ozone, allergens. Air pollution would be under the category of ozone. Obesity can actually influence this because some of these patients that are obese will have esophageal reflux disease, GERD. That tends to bring stomach contents back up into the esophagus. It could actually get its content into the bronchioles. Okay, they could bring some of that fluid in and basically irritate the lining. Okay. So the pathway of asthma on extrinsic is really an allergic response, IgE mediated. Atopic individuals are potentially genetically predisposed. And if you look at what's going on in our figures on this slide, you see in the middle of the slide with the schematics a normal airway, cross section, wide opening right down the middle, and then a constricted airway in the image labeled B due to an allergen-triggered asthma response. Over on the far right of this slide, you can see a refresh for your memory of what was happening back in our immunology section. You can see the classic pollen up at the far right, this pollen allergen binding to an antigen-presenting cell, a dendritic cell in this particular situation. You get a cascade of events that's mediated by an IgE response over on the far left. Mast cells are involved, arrow going down to the immediate phase of an allergy response. You've got this mast cell pumping out a tremendous amount of IgE. You have smooth muscles that are responding. You actually have mucus production. And then over to the right side with the late phase, right, you have excessive mucus production that's taking place. You've got basophil, eosinophils, and neutrophils that are hanging around, and you're facilitating this allergic response in the chronic phase. This is extrinsic. Now, intrinsic is slightly different. It's not an IgE production. At the bottom of the slide here, we're on the intrinsic pathway of asthma. Things that could induce this are cold environment, okay, causing constriction on that airway. Exercise could actually cause constriction on that pathway. It's non-antigen mediated. Stress could actually induce this as well. So it is possible for patients to actually have asthma that are both triggered by extrinsic or an allergy. They may be allergic to pet dander. Okay, they may be allergic to ragweed, certain types of pollen. They may be allergic to dust. Okay, they also could experience challenges with exercise, so they have exercise-induced asthma. So these are our patients that really are struggling with asthma in more of a chronic sense, but we would still try to treat these patients and mitigate these symptoms over time. So let's take a look at it microscopically. We've got two histology images here, one a higher magnification of the other in certain areas. The first image, upper left, you've got bronchial cartilage on the far right, okay, the darker purple with these sort of round oblong structures. That's our bronchial cartilage. And on the far left, we actually see the bronchial lumen. And you can see that it's filled with mucus. It should be actually wide open. So all of that is actually mucus. And in between the far right and the far left of this upper left hematoxylin and eosin stained image, you can actually appreciate that there's a tremendous amount of eosinophils. These eosinophils are responding to edema and inflammation. Okay? So all of these sort of red purplish dots, now let's move to the bottom right hematoxylin and eosin stained section, and you can see these oblong structures with the red dots inside. Those are red blood cells. So that's actually somewhat normal. But outside of that, you see in the extracellular matrix, you see a population of inflammatory mediated eosinophils that are present there. Switching gears to bronchiectasis. Bronchiectasis is really referred to as permanent bronchial dilation. It's typically due to an obstruction. Okay, it develops due to inflammation. It tends to weaken the bronchial walls. There's destruction of the muscle and the elastic supporting tissue. So here in this image on the far right, what you're able to appreciate is that the mid-lower portion of the lung is where you can see present dilated bronchi. Okay, all of these basically little holes in that mid-lower part of the lung. The upper part looks fairly okay. The lower part looks fairly okay. I see in the upper part, towards the bottom of the upper lobe, a few areas of dilated bronchi, but most of the dilated bronchi are organized to the mid-lower part of this lung. And so what's going on here is you've got an obstruction or an infection. There's inflammation. The bronchi are damaged. There's permanent dilation. And there is purulent sputum that is produced. A cough is very typical. And the challenge here is that because it stays open, infection is very possible because you basically don't have much changing out of that fluid. Even though you have a productive cough, you've got a dilated bronchiole and there's sputum that gets caught in there, so it's at risk of becoming infected. So that's where you have this chronic necrotizing infection that can take place. So the features: sputum is foul smelling, it's copious, meaning it happens all the time, shortness of breath or dyspnea in these patients, there's a cough, they tend to run a fever because they have an infection and the body's responding to that. There's an increase in the risk of bacterial infection with these patients of bronchiectasis. There's another situation with cystic fibrosis that we need to characterize here because unfortunately these patients actually do develop this bronchiectasis as well. So cystic fibrosis is an inherited disease that causes a very thick, sticky mucus to build up in the lungs, as well as the digestive tract. It's one of the most common chronic lung diseases in children and young adults, unfortunately. This concludes part 1 of 2 parts, so you'll want to close out this video file and open up part 2.